I will be talking on the principles of the surgical treatment. When do we fix them with screws, plates, or fuse? Let us start with a case. Usually, Lisfranc injuries can be low velocity, low energy injury, or high energy injuries like this. When, as Chetan sir has showed, they have loaded in plantar flexion, and this can happen in two-wheeler accidents as well as fall from height. So when this kind of midfoot injury is there, obviously look for soft tissues. Soft tissues may take time to settle down. So while you are operating, it's the soft tissue like pilon fractures. We say that soft tissues are going to predict the outcome. Similarly here, watch for soft tissues to settle down. And then we investigate, but then we get such kind of CT scan. Probably they had no information to us. So we should go to the console and read our CT scan ourselves. When we advise CT scan, what technicians they do, they give you in such kind of sections which are for the ankle. If you want to really study midfoot, probably you go back again and you can align your sections like this, which are parallel to the midfoot, and they will yield more information. And this can be done later also. Once they have taken the CT scan, you go back and align the axis in this manner so that you will read your CT scan yourself. And I don't know why it is not running. Okay. So see this now. Can we stop it here? Okay. See this concentricity of a joint. How to read a CT scan. These are not parallel. See this. Those when they are not parallel, they are injured or unstable joints. And then of course 3D CT scan. But again, those all sections which we studied, actually those videos, they did not work, but they are important. And then you should know what are the joints involved. And this is going to give you information, but this is very important. On CT scan, particularly when you have taken sections, see that two joint surfaces should be parallel. If they are opening somewhere, then these joints are involved for sure. Then again, soft tissues are important, and then we went ahead and did this particular fixation. Now watch here. This is rigid fixation on the medial column. Medial column is first, second, third, as Chetan sir had just shown. First, second, third, this is a medial column. Lateral column can be fixed with K-wire. So and this is a follow-up. This is how it went on to heal. So you should read your CT scan yourself and align the axis. And at tarsometatarsal level, that is at the Lisfranc level, medial column is rigid, needs rigid fixation, and lateral column is mobile, can be fixed with K-wires. Okay, so this is very important. If you can take your own hand and see, just manipulate your fourth and fifth, very mobile, and see first and second, you cannot. Similar in the foot, fourth and fifth is that mobile and needs mobility. And first, second, third, they are rigid, needs rigidity. So, but this is at tarsometatarsal level. If you go to chopart level, talonavicular mobility is most important. So again, read this slide carefully. At Lisfranc level, medial column is rigid, needs rigidity, and lateral column is mobile. But at chopart's level, it is different. Chopart level, talonavicular is very mobile. So medial column is very mobile. That is just proximal to it. So when you are fixing, see that you fix more rigidly on medial side. Now, a few things. While fixation, what is better, screws or plates? Literature has shown both having good outcome, but at least don't use K-wires for medial column. And these are papers which talk about even screw fixation or plate fixation, but only logically you see this cross section. When you are passing these screws obliquely, they do damage the articular surface significantly. And if you have made 2 or 3 attempts to pass those oblique screws, then probably we are not doing good justice for the articular cartilage if you want to salvage the joint. If you are fusing the joint, then probably screws across the joint, they are good. But if you are salvaging the joints, then those spanning plates will be better. Another case where multiple fractures again, read your CT scan yourself, try to understand what are the joints involved. And so many times these joints will go unnoticed and you will notice only the displaced large fragments or the column. See the soft tissues. Now understand that second is the key. Second displaces laterally and dorsally. So reduction maneuver is this tongue sits laterally and dorsally, and this tongue sits plantarly and medially, and just approximate it. So medial tongue is plantar and medial, while lateral tongue is dorsal and lateral, and just approximate. This will give you reduction. So reduction is important. Start with second and then you may go for the medial side. And I don't know, I have checked why those videos are not working. A beautiful intro of how to see the instability. I'm running. So again, this is home run screw. You can pass it from medial column to second or second to medial cuneiform, but this is easy. Second to medial cuneiform, and again laterally K wires and plates on medial side. So suture button device can be used. I have not used it. One word about low energy injuries. Ligament injuries, on the contrary, they are more unstable, and whatever primary fusions are indicated, probably they were for low ligament injuries. And see this, how they are unstable. All ligaments are gone and very little scope for fibrosis there. So they were fixed. Primary orthodesis, last slide. There was paper of 2012 which advocated primary orthodesis, but now it is clear that the both results in both cases are same, unless there is a significant comminution. In this case, we went ahead with the primary orthodesis. Last slide, sir. Just algorithm. If it is unstable Lisfranc fracture dislocation, high energy trauma or open fractures, you may go for primary K-wires temporary or go for open reduction. Okay, this is simple. If it is Lisfranc which is undisplaced or ligament injury or no dislocation, but there is plantar ecchymosis, then get weight bearing X-ray or stress view. We will discuss when we get time how to get this stress view. If weight bearing X-ray is negative, it is stable and no dislocation, then put cast. But even if you are conserving, please repeat the X-ray after 2 weeks. If stress view shows instability, unstable, then either go for open reduction or go for fusion, because these are the ligament injuries which will cause issue. Thank you so much.